Well, thank you guys for joining us today. We're going to get started. The title of this is Removing the Veil from Home Sleep Apnea Testing. We're not going to get into a bunch of detailed waveforms and all that. We just want to look at the usefulness and some of the disadvantages and limitations of home testing so that everyone can understand more what we're doing as sleep providers by using so much home testing in the last few years. So as an overview, we're going to do it sort of as questions. So let's get started. Number one, which of the following is not a possible result from a home sleep apnea test performed on a patient with risk factors for obstructive sleep apnea? Which of the following is not a possible result that you should get back from a home sleep test? A, negative for OSA or normal, B, positive for OSA, C, severe OSA, or inconclusive. And the answer is A, negative for OSA or normal. Home sleep tests underestimate the amount of sleep apnea, and they have night-to-night variability, and they cannot be normal. They cannot be negative. They are inconclusive. They cannot exclude a diagnosis of OSA. Only an in-lab polysomnography overnight can rule out OSA as a diagnosis. And this is really important, why I'm really focusing on this first, because we want to save lives. And untreated OSA has a mortality as high as 40% over 12 to 15 years. And so many individuals that we get home tests back from other companies and other providers are read as normal, and they're not. In fact, you'll find out later as much as 90% of patients who have test results coming back as normal or negative actually have OSA. Furthermore, home sleep tests can't be mild or moderate because they underestimate the amount of OSA and the severity. So they can only be positive, in which you have to assume they're likely severe, or they're severe because they have an index greater than 30, which means they're probably 60 on an in-lab, or they're inconclusive. Think of it like trying to diagnose diabetes with the urine sugar, okay? Now, the blood sugar has to be about 180 in order for it to spill into the urine. So yes, anyone who has a positive urine sugar is obviously going to have diabetes, but you're going to miss a lot of the patients who also have diabetes because of the way you're testing. Question number two, which of the following should not be your next step after reviewing the results from a home sleep apnea test? Prescription for auto-adjusting CPAP, which is called APAP. It's where the pressure adjusts during the night on the patient instead of putting them in the lab to find out the exact settings they need. B, prescription for oral appliance to treat sleep apnea. C, an in-lab polysomnography, or D, all of the above. Which should not be your next step after you've gotten your results back from your patient on HSAT? Well, the answer is B, a prescription for oral appliance to treat OSA. Remember, home tests underestimate the severity of sleep apnea, and they also have night-to-night variability. So HSAT should really only result in two things. They're either positive, where you're going to put them on CPAP or APAP, or they need to come in the lab. Oral appliances can only be initial therapy for people who snore or have mild OSA. They're unlikely to work in moderate sleep apnea, and they're really, really unlikely to work in severe sleep apnea. So the other thing is, if you see evidence on the home sleep test of central sleep apnea or hypoventilation, they need to have PSGs as well. You really can't diagnose those from a home sleep test, but you can see evidence of them if you're looking carefully and if you're looking in the right patient beforehand. So we actually will show you data later in this presentation that a repeat HSAT before doing it in lab is also an option in an uncomplicated patient. So remember, you only really have two choices: either CPAP because they're positive, or they're inconclusive and they need to be further evaluated. Question three, and the last one, I promise. Auto-adjusting CPAP or APAP, with rare exceptions, should always be offered as treatment after a positive result from an HSAT, because, so we're going to give them, for a positive result, they're going to get APAP or CPAP. So, and the reason is A, CPAP is the most effective treatment. B, CPAP is the safest treatment. C, CPAP is the most cost-efficient treatment. D, CPAP provides the fastest access to treatment. E, CPAP has the most medical evidence for its benefit. Or F, all of the above. Well, I think this one's fairly obvious. The answer is F, all of the above. CPAP is the most effective treatment. 98% of patients, even with severe OSA, are treated. Now, they have to wear it, okay? That's a different issue, but it is effective and treats everyone. You have to understand mouthpieces, will treat probably 70% of mild. It drops down to moderate. When you get to severe, it's very small. Surgery is really the same. The exception would be an Inspire is more effective, but Inspire has to come in after someone's failed CPAP, and it's not as effective as CPAP. CPAP's the safest. It basically can't hurt you, a rare allergy to the latex or silicone. Obviously, mouthpiece can move your teeth and can cause TMJ. The worse your CPAP, the worse your sleep apnea is, the more the mouthpiece has to pull, so the more likely it is to cause TMJ, and of course, the less likely it is to help you. Obviously have side effects and complications from surgery. So CPAP is the safest. It's the most cost effective. CPAP costs a fraction of surgery. I mean, surgeries are up to $50,000. CPAP $600 to $800. Mouthpieces start at $1,500, go up to $4,000 depending on the dentist. CPAP's even less expensive than statins and many hypertension meds if you look over 5 years. Our big thing is, sleep apnea is a bigger risk factor for heart disease and cholesterol, high blood pressure, and yet everyone gets their lipids or the blood pressure checked, but people aren't getting checked for sleep apnea, and the cost is actually less. And finally, CPAP actually reduces healthcare costs. It's actually tremendous amount of reduction. There's tons of literature on this. There's no data for the other medications or treatments reducing healthcare costs. So it's the most cost effective, far and away. Accelerated treatment, I can have you on CPAP within 48 hours after your home sleep test. Even in other states that we're treating, have it shipped to you and do the setups virtually. It takes weeks or months to get a mouthpiece made, certainly to get surgery approved. And then finally, the most evidence. There is a mountain of evidence that CPAP reduces cardiovascular events, improves survival, hypertension, insulin resistance, cognitive function, quality of life, daytime sleepiness, depression, erectile dysfunction, gastroesophageal reflux. We can go on and on. There is no evidence about surgery doing these things. There's a minuscule amount of evidence that a mouthpiece will, a minimal amount of evidence that a mouthpiece will improve daytime functioning and also more recently improve high blood pressure. I think well, it said my internet was unstable for just a second, and if everything's fine, I'll keep going and leave my video on. Otherwise, if it does that again, I'll turn my video off so you can see the screen better. All right, so let's dive in. What do home sleep apnea tests actually test for? I know it sounds like a stupid question, but the answer is yes, they test for sleep apnea, but what really is sleep apnea? Well, the definition, people use is repetitive partial or complete obstructions of the upper airway during sleep. Partial obstruction being hypopnea, complete obstruction being apnea. The problem is most sleep-related respiratory events are not complete obstructions or apneas. They're partial obstructions called hypopneas, and you hear them with a snore. We have patients all the time come in, doc, I snore, but I don't hold my breath at night. I don't have sleep apnea. Well, Mr. Jones, it's the same thing. That snoring is the main sign of sleep apnea in many people. The official name of this syndrome is obstructive sleep apnea hypopnea syndrome, because you got to include both types of respiratory events. We usually just say OSA for short to signify that it's obstructive sleep apnea, not central sleep apnea. And all these different types of respiratory events are collectively called sleep disordered breathing. So doing home testing, we're just not looking for obstructive events. Yes, it's only good at finding those, and of course it misses a lot of them, but you have to also look at the other types of sleep disordered breathing. So let's talk about them. Starting with the obstructive type. There's snoring and there's obstructive sleep apnea. Both of those represent obstruction of the airway. Snoring is no longer a laughing matter. It's a sign of someone's airway partially occluded. It's a sign of someone struggling to breathe while they sleep. It's a sign of someone who's likely going to get hypertension, heart disease, and diabetes down the road. It's a sign of someone who's not going to feel their best the next day. And half of American adults have snoring, and 80% of those already have sleep apnea. And the others are probably going to get it during their life because sleep apnea increases with age and increases with weight. Now, of those 80% that have, a recent study showed 37% of US adults have sleep apnea already. And we're going to talk in a minute how do you know the difference between obstructive sleep apnea and snoring? And of that 37%, half of those, 18%, have moderate severe. In the moderate severe cases, this is where the mortality really goes up. This is our job as providers, is to identify and treat the moderate severe cases in our communities. 85% are undiagnosed, and of those diagnosed, less than half are on effective treatment. And this problem is worse in the South because the obesity is higher in the South, possibly for socioeconomic reasons, but because the obesity is higher, sleep apnea is higher. Because sleep apnea is higher, you have more hypertension, you have more diabetes in the South. So it's more than 37% in the Southeast. And guess where it's even higher? It's in your waiting room, because the patients that have the different problems that sleep apnea causes comes to see you. And they're sitting out there, like 86% of your diabetics with a BMI over 30, type 2 that is, not type 1, no relation to type 1. 65 to 70% of strokes in heart patients. It goes on and on. Even those undergoing surgery, 70% have, and I think a lot of that's because obesity increases your chances of needing surgery. 77% of people with BMIs just over 30. And of course, we know 40 to 45% of Tennesseans have a BMI over 30. And of course, 80% of people who snore. So, you know, if I went to rural Colorado and tested randomly the thinnest state in the country, I might find 15 to 20% with sleep apnea. If I went to a mall here in Tennessee, I might find 40, 42%. But if I went to your waiting room, I might find 60%. But there's one place where sleep apnea is even more common, and that's my waiting room. My waiting room is the collection of all the patients that you've identified from your waiting room and referred to us. I don't get to choose which patients we see. We're physician referred. So my waiting room, believe it or not, for those who are sent for sleep apnea, not for insomnia, not for other sleep disorders, but sent for possible sleep apnea, 97% of what we see has sleep apnea. That may sound ridiculous, but you got to think of how they got there. That, you know, the providers, primary care providers and cardiologists who are sending them to us, they have great specificity. I mean, you know, they're 97%. If you send it, guess what? You're right. Now, I think the sensitivity could be a little higher, but the specificity is fantastic. So let's talk about other types of sleep disordered breathing. We know obstructive is, you know, by far the most common, but central sleep apnea is not as uncommon as people used to think. Now, one of the common things we get that's not central sleep apnea is other labs and other providers will send us a patient because they had central sleep apnea diagnosed in their lab and they wanted us to manage it. Well, we go through, they don't really have central sleep apnea. When you go to sleep, your PCO2 goes from 40 to 45, and you're going to have a 10-second period, very likely, where you don't take a breath. Well, that would count as a central sleep apnea event. And so patients with fragmented sleep who wake up and go back to sleep over and over through the night can actually be incorrectly diagnosed as central sleep apnea. And so we tell a lot of people who are sent to us for central sleep apnea that they really don't have it. Now, as far as those who do have central sleep apnea, well, it's getting more and more common, and particularly with heart failure patients. 1 in 3 have central sleep apnea, and this is a whole issue we're not going to get in today. But these patients need to be identified, and it gets complicated on how we treat them. But something as a primary care you see all the time is someone on opioids. And, you know, with this epidemic in Tennessee, it's something else. 25% of those patients will have central sleep apnea. So this is why we need to be doing consults on patients, knowing the history of patients, because we can only really interpret the home sleep test based on the history of the patient. And then the biggest problem we're having is with treatment-induced central sleep apnea. When you treat obstructive sleep apnea with positive pressure or CPAP, 15% or 1 out of 6 are going to develop treatment-induced central sleep apnea. In other words, the pressure causes a reflex where they actually have a central event. What happens is the respiratory therapist from the DME company trying to manage them without sleep medicine supervision, you know, sees the download, sees they're having these events and thinks, okay, I need to increase the pressure. Well, as you increase the pressure, you just increase the central events, and it doesn't help. The patient's pressure gets higher, they can't tolerate it, they just quit, and it's a treatment failure. So this needs to really be monitored. High altitude breathing, you think it's not an issue, but there's a subset of men over 50 that are very sensitive to altitude that will really have this even in the Smokies or the mountains or the Blue Ridge. Obviously, we had a patient recently who, when they were at their Deer Valley place, they'd have all these events on their download, and they come to Nashville and they were normal. So it can be treated. It's a little more difficult. When we find central sleep apnea, and I don't have an explanation for one of the ones up the list, well, we do an MRI, and believe it or not, we usually find something. And the Chiari-1 malformation is the most common thing we find. The third type of sleep disordered breathing is nocturnal hypoventilation. Everyone's heard of obesity hypoventilation syndrome, formerly called Pickwickian syndrome, from the Pickwick Papers, the Charles Dickens novels. He was the first to describe it, I guess. But anyway, it's much more common than I used to think. And a few years ago, we had to start addressing this. Up to 40% of patients with a BMI over 40 have this. Up to 50% of a BMI over 50, and it increases as the BMI increases. So how do you screen for this? Well, a great way is to do a serum bicarb. But the bicarb is less than 27, they're not retaining CO2. So you pretty much exclude that. If it's over 27, you need to think further. But there's other reasons. They could be on a diuretic, and that would certainly do it. This needs to be looked at because these individuals may need a different device than a CPAP, or a BiPAP, or an ASV, adaptive servo ventilator, or something else. The other thing is hypoventilation and COPD. When patients become CO2 retainers, they begin during sleep. They first become retainers during REM sleep because of the muscle paralysis that people have during REM, so they don't act out their dreams. So when patients are needing accessory muscles to breathe in COPD, guess what? They hit REM sleep, they don't get those, and so they begin to hypoventilate. Of course, as their COPD worsens, this goes to other parts of sleep, and of course during the day. So always think of COPDers, that's why we look at their REM sections on their in-labs very carefully. We need that history on the patient. The combination of COPD and OSA is a deadly combination called overlap syndrome. With a person with normal lungs might have a 3 or 4% desaturation on a sleep study. If they have COPD, that same amount of obstruction in the airway may be a 20 or 30% desaturation, which accelerates the path to pulmonary hypertension and right heart failure and early death. In the OSA trial, that's obstructive lung disease and sleep apnea, a 10-year study that just came out in February, CPAP actually doubles the survival. So it's really important, your COPDers, that you identify sleep apnea, obstructive sleep apnea present in them, and of course we need to be looking for hypoventilation in them. Patients with neuromuscular disease should not have home studies because hypoventilation is so common that they need to have in-labs. There's also a couple other rare causes of hypoventilation we pick up here and there. This is our pathway to treat patients referred to us from cardiology because central sleep apnea is so prevalent that our providers follow. And down the right side is treatment of obstructive sleep apnea, and down the left side is treatment of central sleep apnea. I'm not going to go into this today, but this is what the pathway you have to think through when you're dealing with these individual type patients, especially heart patients, using home testing. So why do we test for sleep apnea? We've looked what we're testing for, but why do we do the test? Well, the main reason is mortality. On the left is the American study, and you can see the mortality of an AHI, apnea-hypopnea index, from in-lab over 30 is 40% in 15 to 16 years. That's pretty significant. Untreated, you can see compared to an AHI less than 5. Even mild sleep apnea, 5 to 15, has increased mortality. You can see at above 15, the mortality really goes up. And this slide is really important because you look at the Australian study to the right, it was done with home studies. So you can see an index of 15, an RDI of 15, actually has a higher mortality, less survival at 12 to 15 years than an in-lab greater than 30. This is the best example I can give anyone on how home tests underestimate the severity of sleep apnea. The severity is not a number. The severity is the mortality, all right? And so you have to apply these numbers to a mortality to really determine that. And so when you're doing in-labs and you're above 15, well, that's a moderate. On a home study, if you're just positive, you're in that range. And that's, again, why home studies can't be mild, can't be moderate, and they cannot be normal. CPAP reduces cardiovascular events, all right? You look at the green line at the bottom, those are the controls in this famous Spanish study from 2005. And you look at the red line, which is severe OSA, and you can see the increase in cardiovascular events over 12 years, 144 months, was 7 times almost. Now, the most cool part to all of us about this study is the blue line. The blue line are individuals who would have been on the red line, but they put them on CPAP. And you can see that CPAP reduced cardiovascular events by over 2/3. So what's the difference in snoring and sleep apnea? Well, the difference is, does the brain react to it? This partial obstruction of the airway that makes this noise, this vibration sound we call a snore, you know, if they just obstruct their airway, but the brain doesn't care, well, then you don't have sleep apnea. But it's when the brain responds to it that leads to all this whole mechanism and pathway that is sleep apnea. So the brain responds with an arousal or a release of norepinephrine because it's trying to awaken the pharynx. So the muscle tone comes back like it is during the day. You don't snore during the day, only when you go to sleep because the muscles relax. So the brain wants to arouse the pharynx. I've always said if you could keep the brain asleep and the throat awake, you'd cure sleep apnea, and that may be coming in the future. But the brain reacts to decreased O2, increased CO2, and increased diaphragmatic effort. So the consequences are, well, you get arousals in your sleep. Norepinephrine is the main awake neurotransmitter. So the release of norepinephrine all night is going to increase your blood pressure. It's going to increase your blood sugar, which increases your insulin and leads to insulin resistance, causes heart disease, causes daytime sleepiness, memory and cognitive issues because of the fragmented sleep. And of course, all this release of stimulant leads to anxiety and depression. And of course, this is a big limitation to home sleep testing, particularly the airflow type devices, is because they don't pick up these events. They don't have any brain waves. They don't know you're having arousal. They don't know you're having a sympathetic release. Second mechanism is O2 desaturation, but really what's more dangerous is the resaturation, which is a reperfusion injury. So when you desat, drop your oxygen, and then that area, when the oxygen comes back up, that's when the free radicals are produced. They can damage the intima of the blood vessel. And of course, that damage then leads to the repair, which is often plaque that leads to atherosclerosis. And that's where we get coronary artery disease, cerebral vascular disease, erectile dysfunction, and white matter damage type dementia, not a Lewy body or Alzheimer's. And so the big study in Milan in 2015 showed that this white matter damage by MRI could be reversed with 1 year of CPAP. The third mechanism is negative intrathoracic pressure. Obviously, you're having to create large negative intrathoracic pressure to get air across an obstructed airway. That negative pressure brings stomach contents back up into the chest and into the throat, especially when you're lying supine. That negative pressure brings more blood into the right atrium. It gets distended. It thinks you're volume overloaded, releases alpha natriuretic peptide, which goes down to the kidney, turns on the nephrons, and makes you have to get up and go to the bathroom at night. Sleep apnea is the most common cause of having to go to the bathroom at night, even in diabetics. So we have patients that get up 5 and 6 times a night. You put them on CPAP, they don't get up the next night. This is also a cause of left ventricular dysfunction because, of course, you're putting the heart in this big negative pressure. It has to generate more positive pressure to perfuse the body. And, of course, this distension of the right atrium can lead to remodeling and atrial fibrillation. Of course, you know, atrial fibrillation's relation to sleep apnea is huge right now. So think about all your AFib patients, because we know those patients that are put on CPAP have much less chance of recurrence of AFib after cardioversion or ablation. The types of home sleep tests, obviously the in-lab polysomnography with all the wires on the lady is the standard, the gold standard. Home sleep testing, the picture on top is an effort-based device. The picture on the bottom is the WatchPat. We'll talk about both those. And of course, there's these non-FDA approved devices. Please do not try to diagnose, or actually it wouldn't be you, it'd be your patients who are trying to tell you they don't have sleep apnea because of their device, or that they do. Usually an app on their phone. The gold standard, you know, obviously it tells us everything. On 40,000 of these we've done over 30 years. I don't think we've repeated 5. You don't have the night-to-night variability. You actually see everything. Sometimes you don't get them in REM on their back, which does limit a study. But I mean, this 14 channels, we have EKG, we find arrhythmias, we find leg movements, we find all other kind of sleep disorders, and we can actually classify what their sleep apnea is. Is it mild, moderate, or severe? Or are they normal? So that's the advantages. The disadvantages is price, inconvenience, and limited access. This is from the internet. This is the charges. I don't know what their allowables are. Well, actually, I do know what a lot of these allowables are. I just can't tell you. And that's our charge at the bottom. Of course, Medicare pays us about $440 technical for in-lab. So, you know, yes, this is why we need home testing, because sleep apnea is so prevalent. These tests are expensive. There's limited access. It's inconvenient to come spend the night. But in some cases, if the price is low enough, like for our Medicare patients, and the amount of information you gain and the percentage of inconclusives you would get where they'd have to have an in-lab afterwards, sometimes in-lab is a better decision. But for the most case, it's not as fast, and we tend to use home testing whenever we can. The effort-based devices, you can see the little nasal cannula in his nose. It's measuring pressure changes. That pressure change is calculated to a flow, so that gives you a flow signal. The problem is with home studies, one of the reasons they have so much night-to-night variability is you don't ever get a good waveform all night. You know, they move in bed, it changes. You know, in an in-lab, the tech can come in and adjust the sensor and fix it immediately. But with home studies, you just don't always get a great test. And it's much harder to read. It takes much more time, actually, sometimes to go through and try to figure out what are you seeing there on these waveforms. The WatchPat's the new thing, okay? They've been out about 6 years. Well, we just started using them last year, and of course, you know, we've done like 1,600 in the past few months. So we didn't use it the first few years because you couldn't get in and actually look at the raw data and really verify and determine it. Well, they started that a couple of years ago, and the other thing they did is they added this little blue sensor that slides up your shirt and goes on your sternum, and that's really improved the sensitivity and the specificity for not only obstructive sleep apnea, but also for central sleep apnea. So we have really made this our home testing of choice. It's really fascinating. It doesn't measure airflow. So you're not really picking up the hypopnea or the apnea. What you're picking up is the brain's reaction to it. You're picking up that sympathetic release of norepinephrine, which changes the tone in your vessels. Just like we see on an in-lab with EEG changes, this changes the tone in the peripheral artery tone. And so it uses peripheral artery tonometry plus about 7 other channels. I'm not going to get into the details of all the waveforms, but it's actually picking up the response. Now, the other thing is the little blue probe has a microphone, so it picks up the snoring as well. But this is really cool. It can actually tell if you're asleep and tell which stage of sleep you're in, because it changes in arterial tone during different stages of sleep when you coordinate that with heart rate. So fascinating device. The WatchPat 1 you see here on the right, download the app to your smartphone. The patient in the morning when they hit their phone to end the study, we have the results in 45 seconds, and we have called many patients before breakfast to go over their results. Which index? We got all these different indexes to measure sleep apnea, and we need to talk about that because it gets very confusing because they're all different and you can be misled. So the number of apneas for airflow type measurements like in labs and the airflow type home studies, you take the number of apneas and the number of hypopneas and you divide it by the total sleep time, and that gives you an AHI, apnea hypopnea index. All right. Now, it's not that clear because how you define hypopnea affects the numerator, or whether you can measure the hypopnea. Medicare doesn't measure arousal hypopneas, which is standard scoring. The whole world does it one way, and of course, Medicare has to do it differently. We don't ever make clinical decisions based on a Medicare index. We make clinical decisions based on standard scoring. All right, but we use Medicare to figure out, well, are they going to cover it, or what do we have to do different? So remember, home studies, you don't have any brain waves. So you miss all those arousal hypopneas as well. So the numerator is going to be smaller. All right, the total sleep time on a home study is the recording time. Now, if they slept from the moment they put it on to the moment they turned it off, well, guess what? It'd be the same, but that's not usual. So the denominator is going to be larger and the numerator is going to be smaller. Again, you can see how home sleep tests by effort flow devices underestimate the amount of sleep apnea and therefore can't be negative, can't be mild, can't be moderate. More specifically, on an in-lab, we went over this a little bit, but if they're less than 5, they're normal, and they really are normal, okay? Now, it is true that an index of 4 long-term has a little higher risk of high blood pressure than an index of 1 or 2, but still, that's considered normal. If they're 5 to 15, they're mild, and there's multiple treatment options, including the mouthpiece. If they're moderate, they really need CPAP. Obviously, if they're 5 to 15, they're mild and they have heart disease or diabetes or hypertension, they need CPAP, because we know CPAP improves those things. And of course, they're over 30, they're severe. They always need CPAP. Other things aren't going to fix them, at least not first line. But on a 4-channel or 3-channel home study, if they're less than 5, and this is REIs, or respiratory event index, it is not an AHI, it's inconclusive. If they're greater than 5, you have to assume they're moderate severe and go ahead and try CPAP. If they're greater than 30, they clearly are greater than 30, more likely 60. So these different indexes, we talked about the AHI, the standard, and that's from an in-lab, and that's what we make clinical decisions from in-lab. The Medicare index underestimates the severity. We just do it based on payment. If you're using a facility, an in-lab facility near you, and you're in Georgia or Tennessee or wherever, and on your Medicare patients insist they do standard scoring too. A lot of the labs, I'll say most of them, just do Medicare scoring on them. Well, it'll tell you whether they're positive and they need treatment, but it's not going to tell you their severity if you want to have other options for them. And they've done the same test. They can easily score it both ways. We do every study and always have done every study both ways. An RDI is confusing. It includes another type of event, which is more subtle. It would actually overestimate the amount of the AHI if you use the RDIs greater. We don't use that. There are some patients we've done in labs on where all they had were these respiratory event related arousals, and they do get better on CPAP, but these are rare cases. From home studies, well, the REI from an airflow, remember it dramatically underestimates the severity. The PAD index, it's actually probably better because it gives you more accurate sleep time, because you actually get a real sleep time. The ODI, the oxygen desaturation index, you just can't use that alone. That's like putting a pulse ox on them overnight. But it helps verify the validity of the home test. And then the thing to be aware of are the PAT machines. For marketing about 15 years ago, they began to put these indexes, they call it AHI, on the CPAP machine or the download that you get from your patient's CPAP machine. And they can be helpful clinically, but they're not accurate. Beware, if the patient's having symptoms of sleep apnea and their index is normal from their machine, guess what? They're having sleep apnea. Do not believe it. And further evaluations needed. So this is 1,600, the last 1,600 watch pats we did. Well, maybe we've probably done another 100 this week, but you can see that 21% are less than 5 and clearly inconclusive. Of those greater than 10, the watch pad is clearly positive. The specificity is incredibly high, approaching 100% at above 10. But our problem is between 5 and 9, and we have to spend a lot of time going through the results of those cases, going through the raw data, trying to determine, are they inconclusive or are they actually positive? But certainly 20% are clearly inconclusive, and further testing is needed. So during COVID, when our lab reopened in May, we actually did a little study. We've done now 40 patients, but this is our data through 27. I haven't analyzed the other 13, but on the first 27 patients that had an inconclusive watch pat, they were less than 5, we put them in the lab, as you're supposed to, but while they were in the lab, we also did a second watch pat the same night simultaneously, and we did an effort-based home study simultaneously. And what we found was astounding, that 89% of those patients who their watch pat basically said they were normal by some people's interpretation, we call it inconclusive, 89% of them had sleep apnea. 89%. And of those, 29% were mild, 29% were moderate, but 42% were severe. So those with, quote, a normal home test, 42% still had severe sleep apnea. And again, it's because of the pretest probability. It's because the fact that, they're out of our waiting room. All right. If you went to the probably some gym somewhere where the BMI is probably 20 and the top age is 30, well, no, you're not going to have this phenomenon. The higher the pretest probability of the population, the less likely you are to get an inconclusive. And of course, those inconclusives will have more normals in them when you study them. Did I say that right? They will have fewer normals in them when you study them. The lower the pretest probability, the more likely you are to get inconclusives and the more normals you will get in that population. All right, so of these 89% of inconclusives that had sleep apnea, guess what? If we repeat the watch pat, instead of putting them in the lab, we would have got 71% diagnosed. If we would have done an airflow study using 4% DSAT, we would have diagnosed 63%. So basically doing a repeat HSAT, we could have identified another 2/3. In other words, that would have left only 8% of patients requiring in-lab. And of that 8%, many would have been mild and had an option of a mouthpiece or another treatment. And of course, the normals would have been in there too from our population. So we think it's very reasonable to repeat HSAT in certain patients that are non-complicated before going on to in-lab after an inconclusive initial HSAT. It's cost effective, it's convenient, it's greater access, accelerated treatment, and currently in today's world, it's safe from exposure. Of course, it depends on the cost and the availability of the in-lab and other medical problems the patient may have. So who do I test? Well, obviously this guy needs testing to save his marriage. And the way we approach it is really, we think, very common sense wise. We group risk factors into A, B, C, and D. Group A risk factors are things like diabetes, where 86% of the patients have it. And if you identify them and treat them, you're making the biggest impact into the health of our community, because those patients are the most likely to have improvement in their A1C, improvement in their insulin resistance, prevention of heart disease, and other things. Patients with heart disease are in there, patients with COPD are in there. And if you possess a group A risk factor, that's enough to get a sleep study. You don't really need anything else. You have a high pretest probability, and you have an improved outcome if you have it and you identify it and treat it. For instance, Down syndrome, 100% of them have sleep apnea, starting at young ages. Group B risk factors would be things like depression, anxiety, reflux, headaches, things that sleep apnea commonly causes. It increases, the prevalence of sleep apnea is increased in those patients, but it's not near to the same degree as Group A, and there's not as much evidence to show the benefit of CPAP in those patients. So like if you combine Group B with some Group C or Group D factors, then again, that's what we would think those patients need to be studied as well. Don't have time to go through all this, but if you'd like a copy of this, we can get this to you. We can show you how we use it. And I think it'll really help you in your practice identify and treat this horrible disease we know is sleep apnea. You compare it to COVID. The mortality of COVID, if you remove just one segment of the population, is about 1%. And sleep apnea is 40% over so many years. You got, 6 million cases of COVID, over 4.5 million last week, so I assume 6. And you've got 60 million cases of sleep apnea. So, it's a bigger epidemic that we're not addressing. So this is the old-fashioned way we practice, and this is how most sleep medicine doctors practice. The primary care cardiologist refers to us. We send them to the lab for a study, then they come back, and then they go back, maybe another study. Hopefully they got split and only had one study. Then they go to the equipment company to get their CPAP. Then the equipment company tries to get them treated and sends them back to the sleep doctor who has to sign off so the equipment company get paid, and then back to the equipment company. It's archaic, it's slow, it's expensive. It's the reason, a small percent of sleep apnea patients are getting that diagnosed and treated. Some primary cares have said, okay, I'm going to do better than that. I'm going to go forward. I'm just going to order the home study from a home testing company and get that result back. And then if they're positive, I'm going to send them over to a DME company and get them treated. Well, that is faster. It does give more access to treatment. It is less expensive, that's for sure. The problem is who's addressing central sleep apnea in the waveforms? Who's looking and taking care of inconclusive results? Are they being told they're normal? Who's managing these non-adherent patients? Because if you do the right things, you can get 80% long-term. If you don't, you're going to get about 30% long-term. Who's evaluating all these other issues? Who's applying the raw data to the actual patient? What about adjusting the study results for the amount of REM sleep or position? And who's doing airflow monitoring to make sure that the initial orders for APAP are being adjusted where the patient, doesn't have sleep apnea the first half of the night because they get put on 5 to 20 and just left there. There's so much. And finally, how do you know when you need BiPAP or ASV? So what we've done with our OSAinHome program is we have defined this crucial moment. The crucial moment in the management of OSA is applying the raw data from the HSAT to that of the individual patient to determine the treatment and further testing. The guidelines for sleep medicine and the position statement of the American Academy of Sleep Medicine says the raw HSAT data, that's all those waveforms, must be interpreted only in the context of the patient's complete medical and sleep history. Just filling out a little order form for a home test and blah, 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 and marking they have high blood pressure isn't going to satisfy that. Also, there's strong evidence in the literature that board certification and ASM accreditation of the facility are associated with improved outcomes. The problem is there's a shortage of sleep medicine providers like myself, and it's only going to worsen because there's only 148 training spots. So we've built this OSAinHome for us to intervene at this crucial moment without taking over the patient, to help primary care physicians and providers and cardiologists and other specialties be able to kind of be more involved in this management where, we'll do the home test, we'll do a consultation with them, we'll combine the information from both those events, the home test and the consultation, and put that patient in the right mode as far as the next few decisions, whether they need treatment or further testing. Do we identify other things? And then, of course, if they need treatment, we put them on CPAP. They go in our DREAM program, where our respiratory therapists and sleep coaches manage them through remote monitoring with our supervision as sleep specialists over them to get the best outcomes. And yet the primary care cardiologist continues to do their follow-ups, because having the primary care do follow-ups and talk about CPAP with them actually improves adherence. So it's a teamwork where we come and do our part, and without getting too involved with the patient at this crucial moment, and allows us to treat more people down the road as we become rare. So the model is we get an interview with the patient, determine which home test they need, because different types, there's certain limitations, and certain patients need one. Some patients that are on oxygen really shouldn't have a home test, although watchback could work on that situation. They have their study, they have their sleep medicine consultation. If we determine they need an in-lab, well, we'll find we can use an in-lab wherever you currently use it, or wherever you prefer, or find a quality, cost-effective center near you to refer them to. Obviously, if they're close to us, that's the best option. But not necessarily, because sometimes people are employed by hospitals and they feel like they need to use their hospital lab. And so we do that with some of the hospital employed physicians in our area. But for those few patients that need an in-lab. And of course, we're the shortest time to treatment. We get almost twice the adherence, and you can't beat the cost effective and the convenience care. Most patients in this program never have to leave their home. Another thing we're doing, we're just getting ready to publish this paper. Ashley rotated with us last year. She's at Duke doing her fellowship. We have just sort of invented a way to use home testing equipment to do titration at home. There's no CPT code, but this is also keeping more patients out of the lab. We've done about 400 of these, and we're going to publish our first results here real soon. Also, Jamie Andres at Vanderbilt in the sleep department, he's helping us publish all our data on CPAP adherence, that we have found that our integrated program and our DREAM program is getting almost twice the adherence long-term with CPAP. And next month, we're going to do another symposium, and we're going to talk about CPAP, how to set it up, settings, how to follow it, and how to get the best outcomes for your patients. Because at the end of the day, if they don't wear the machine, no matter you have an in-lab or a home study, it's all just a waste of money if we can't get them to wear the machine. Thank you so much for your time, and we'll answer questions.